Okay, I'm going to present a 28-year-old Caucasian male who has a retained deciduous tooth. I've planned an immediate extraction. I'm going to use the multi-drill and base bone from OsteoReady. And the implant I selected is a 5mm by 13mm osteoconverter implant. So here's the retained deciduous tooth. It's in roughly the side of tooth number 20. And this tooth is symptomatic. The patient's complaining with symptomatic pulpitis and has chosen to have an implant placed. Now, I want you to look at the amount of keratinized tissue here and the width of his ridge as I numb him up. We got plenty of room to work with. Nice attached tissue on buccal and lingual, and a nice wide ridge. Now, my technique that I'm going to use to extract this tooth is I'm just taking an instrument to separate the tooth from the attached tissue. I'm going to walk around that, first on the lingual side, and then I'll follow through on the buccal side. And I just want to encircle that tooth all the way around to make sure it's free. So I'm not tearing any of the gum tissue when I lift out the tooth. And then I use an easy out elevator. It's a little bit different than a straight elevator. You use it up down the long axis of the tooth, and it's just a rotation motion. And sort of the teeth of the elevator will just lift the tooth up instead of buccal lingual. And I'm just going to kind of wiggle this tooth around. Come up here to the mesial lingual side here. Make sure this tooth gets loose. Then I'm going to come with a 301 straight elevator and just get a little bit of lift going on, a little bit of expansion of the bone and a little bit of a lift. Here we go. And I've chosen to use a 23 cow-horned forceps, place it in the furcation zone, and I'm just using a pumping motion. Basically because I'm trying to fracture this tooth in half. I want to separate it so I'm not really expanding any of the buccal or lingual plate, and I just want a straight lifting motion. So out comes the distal, next the mesial, and there's my site. And you can appreciate now the buccal and lingual plates are intact. Followed by the 2mm parallel drill. Now I'm going to make a pilot hole with this drill right in that interradicular bone, and I'm going to go to full length, a full length of 13mm, since I planned for a 13mm implant. So I'll take a quick x-ray here to have a look at it and see my parallelism. Looks nice. I'm right where I want to be. And if I need to make some corrections, I can. This is the multi-drill. The multi-drill is going to follow the pilot hole of the parallel drill. And again, in this, for instance, I am going to take it down to full working depth. So I'm going to advance it just a little bit more. There we go. And it is that quick to create an osteotomy. The osteoconverter comes with a hand carrier driver, and I'm going to carry that over directly into the osteotomy site, place it in, and then just drive it down with my fingers until it engages the bone to where I get a tug back to remove the hand carrier. So let me just remove this hand carrier here. Next, I will grab a 2.42 hex driver and place it in the torque wrench and ratchet this thing down to my working depth of 13mm. You can watch that advance. It's going in very nice. There is some pushback from the bone, meaning it is dense bone. You'll see that in the jerking motion of the patient's head. Let's line that up, and I'm going to advance it a little further down. I'm not quite there yet. Okay, let's take a look at this. So there's my implant. I'm also showing you the extraction side of the distal root. I'm going to use some base bone, and this is mineralized cortical bone. It comes in a vial that's 0.75 cc's. and remove the top. And pop the lid off. There we go. I'm going to grab a dampened dish and just place the appropriate amount inside the dish. It just kind of comes out here. There you go. A little bit more. Perfect. All right. Now I have some sterile saline that I'm going to drip in there. And I'm trying to go for a working consistency where the bone will basically stick to my instrument. So I'm going to mix this around and play with it a little bit in the dampened dish until I find the consistency that I like. Now if I add too much saline, I can wick it out with some sterile gauze, but roughly I want it to be able to stick to my instrument. Seem to play with it. Good consistency. It's kind of like building a sandcastle. Carry it over to the site and I will pack it in with a bone condenser. Now the secret to packing this bone is you kind of let the blood work with you. I mean, the whole point of this is to form a clot and to feed this graft. So I'm not drying out this site. I'm working with the blood. And if there is excessive bleeding or excessive materials, you can use a surgical suction to clean things up. But for the most part, I just let the body do its thing. I've also chosen to place a resorbable membrane over the top of this graft. And I'm going to let the blood kind of wick it into place as I tuck it down underneath the gum tissue. And just watch the saturation as it wicks in the blood. And this is forming a clot. So the secret is not to over manipulate it. You just kind of let the body do its thing. Then I'm going to place the healing cap in, and I'm just going to drive that into place with my hands. Just twist it down, engage the implant until I meet resistance. Then of course I can go to the breakaway torque wrench, kind of set where I want to be, torque it into place. There you go. There we go. All right, so let's take this out. Next, I'm going to put in a couple interrupted sutures. I'm going to start with the mesial just to kind of bring the buccal lingual tissues together. This is not under tension. I'm not trying to get primary closure. This is a secondary intention technique. But I'm going to go through the keratinized tissue of the buccal, engage the lingual tissue, and it's a basic interrupted suture. So let me tie this into place. I always like to make sure my knot lays flat. If you pull it the wrong way, it will kind of ball up on you. Keep that flat. Great, one more. All right, we're halfway there. Now on the distal side, we want to be careful not to lift up the membrane. So I'm going to go buccal lingual through the buccal tissue and kind of come up just like that and kind of split the difference between the gum tissue and the membrane. I'm going to lift it up by pulling it out towards the buccal, not towards the lingual, because that will disturb that membrane. Now I'm just tucking that back in so it stays tucked down. And then I'm going to go through the lingual tissue from a buccal lingual direction and try not to disturb the membrane. If I come down low to the crest of the bone there, it tends to pull the membrane down a little bit better. So I'm going to fill the bone with my needle, pull it through. I'm tugging both ends just to kind of pull it down, and then a basic interrupted knot. And again, I like it to lay flat, not ball up, so pay attention to how you tighten if you're pulling the strands in the right direction. A couple more turns here. Tighten this into place. Again, I'm doing very little suctioning because I'm working with the blood in this case. I just want the clot to form, to feed that graft and get that implant nice and tucked in. So there you go. That is it. It's very simple, very straightforward. It's an immediate extraction of a deciduous tooth. We'll see me in 3 to 4 months to see how it's healing and put a crown on. You can see on my x-ray I don't have any space around that implant. I fill that in with the graft. which keeps things nice and happy. And it's another example of how OsseoReady has made our life so easy with this multi-drill and their base bone.